Welcome to Hand Surgery Resources Podcast. Thanks for listening to Hand Surgery Resources Podcast on Ganglion Cyst. This podcast will highlight the major symptoms, signs, and treatment options for ganglion cyst of the hand and wrist. Some surgeons consider the ganglion as a nuisance, but these benign lesions can cause considerable trouble and concern for our patients. Some ganglion cysts cause soreness of the wrist with vigorous wrist activity particularly. Small intercapsular wrist ganglions can cause more annoying pain. Some cysts cause cosmetic concerns, while other patients worry that they have a growth that could be cancerous. Ganglions are typically soft, mucin-filled cysts and account for 50 to 70% of all soft tissue tumors of the hand. Malignancy has never been reported, but patients cannot reliably diagnose their own lesions, and hence their concerns. Ganglions respond unpredictably to conservative treatment, but they can sometimes subside with rest or disappear spontaneously. With proper excision, recurrence is not common, but does occur. Wrist ganglions are related to the scapholunate ligament, the radiocarpal capsular ligaments, or the scaphotrapezoid joint and its ligaments. In the finger, ganglions can be related to the DIP joint or the PIP joint. On the dorsum of the DIP joint area, ganglions are called mucoid cysts and are often associated with Heberton's nodules that occur in the arthritic DIP joint. On the palmar side of the finger, ganglions typically originate from the flexure sheath, often at the junction of the A1 and A2 pulleys, which is under the first flexion crease of the finger. Less commonly, ganglions are associated with bossing of the second and third carpal metacarpal joints, and occasionally the ulnar aspect of the wrist or the sheath of the first extensor compartment. Ganglions are more prevalent in women by a 3-to-1 ratio. 70% of ganglions occur in the 20 to 49-year-old age range. The differential diagnosis includes lipomas, extensor tenosynovitis, and the rare extensor brevis manus muscle or other hand tumors. A typical patient presents with a large ganglion on the dorsum of the wrist and complains the lump is sore, unsightly, or occasionally painful. Some patients are concerned that the lump is cancer. However, ganglion cysts are benign lesions. More often than not, the pain only occurs when the pressure is applied to the lump or when pain was secondary to an injury to the same location, but the pain was not really caused by the cyst itself. Ganglions produce pain at rest and with wrist motion may be small intercapsular ganglions which are not visible and are very difficult to palpate, but sometimes quite painful. A lump that historically fluctuates in size, that is, gets larger, then smaller, and larger again, is almost certainly a ganglion. Very rarely a ganglion can press on a nerve and cause tingling or paresthesias. True ganglion-related pain is minimal and is usually associated with extreme wrist motions. Vigorous palpation during exam can cause some patients to report discomfort. Ganglion cysts are well defined and have soft, smooth surfaces. The cyst is closely attached to the surrounding tissue, but this attachment is loose except at the base where the attachment is more secure. On examination, the location and size should be carefully noted. Cyst location helps us determine the carpal joint ligaments that may be the origin of the ganglion. Typically, the size, smooth, contour, and border of the cyst can be identified by simple palpation. Any attachment to the skin should also be noted. Ganglions have a unique appearance on ultrasound. The size, location, hypoechoic nature, and the relationship to the surrounding tissues can be verified with ultrasound. MRI can also accurately identify, localize, and define the borders of a ganglion cyst, but it is more expensive and more time-consuming to complete. Ganglion cysts can occur in Guillen's canal, adjacent to the hook of the hamate. In this location, the ganglions can compress the ulnar nerve, sometimes causing sensory or even motor problems. Treatment options for ganglion cysts, once the diagnosis is established by history, examination, and ultrasound, include observation or aspiration with or without cortisone injection, or wrist ganglion aspiration with application of a short-arm cast for 3 weeks. Surgical excision of a ganglion is an option for all ganglions in any location. Aspiration of the ganglion also can be a therapeutic alternative. In addition, ganglion aspiration can provide a diagnostic assurance to the patient and even to the physician. Before aspirating either a wrist or a finger ganglion, the area should be thoroughly prepped with an antiseptic solution like alcohol. The surgeon should use sterile technique, including sterile gloves. The proximity of the ganglion to surrounding nerves, veins, and arteries should be assessed so that injury to these structures can be avoided during aspiration. Next, the area of the cyst should be anesthetized with local anesthetic like lidocaine. Occasionally, small superficial ganglions require only a cold spray applied to the skin for anesthesia. The cyst will typically be aspirated with an 18-gauge needle attached to a 5 cc syringe. The surgeon should be able to feel the needle penetrate the skin and then penetrate the cyst wall. Once the cyst is entered, the clear mucinous material can be drawn into the syringe. During this maneuver, the cyst should be visibly deflating. The thickness of the mucin material can sometimes make this aspiration difficult. The needle is withdrawn when the aspiration reveals no further filling of the syringe. This is followed by manually expressing any remaining mucinous material through the needle track by applying gentle pressure to the cyst walls and milking the cyst contents towards the needle track opening. A relatively large amount of additional material can occasionally be removed with this maneuver. It is wise to show the patient the aspirated material. The clean mucinous material that looks like clear, colorless jelly is pathognomonic of a ganglion. Obtaining this clear mucin material is almost as diagnostically accurate as an excisional biopsy of the whole cyst. Band-aid or dressing can be applied to the needle track. Recurrence of the ganglion aspiration is high. Recurrence rates frequently are over 50%, but the patient may request an aspiration before agreeing to surgical excision or just because the patient wants confirmation of the diagnosis by seeing the removed mucinous material. Some surgeons inject steroid at the time of aspiration, but this adds the risk of skin depigmentation and/or subcutaneous fat atrophy, with little evidence of lower recurrence rates. In the past, surgeons have also tried injecting hyaluronidase enzyme after aspiration, but this also does not affect the recurrence rate in any meaningful way, and recurrences as high as 70% have been reported, along with the risk of allergic reactions. Because of these findings, hyaluronidase injection after aspiration has never become part of the routine standard of care for ganglion cysts. The goals of surgical treatment for ganglion cysts are 1. Completely remove the cyst through an incision that leaves nearly an invisible scar. 2. Avoid any damage to the adjacent nerves, arteries, and tendon. 3. Remove the capsular or ligamentous origin of the stalk while remaining and maintaining the function of the wrist ligaments, joint capsule, and flexor tendon sheath. 4. Avoid infection. And 5. Minimize recurrence of the cyst. Optimal treatment for a ganglion cyst can be highlighted by discussing the excision of a common dorsal ganglion. First, a transverse incision through the skin and into the subcutaneous tissues is done. The dorsal sensory nerves are protected during this dissection. Upon opening the skin, the ganglion is usually visible. Next, the subcutaneous tissues are dissected off the edges of the ganglion, retracted to expose the circumference of the superficial part of the cyst. At this point, the pseudoretinaculum or tenosynovium covering the more distal extensor tendons is visible and partially removed to expose the tendons and protect the extensor tendons near the ganglion during the remaining dissection. Cutting the dorsal wrist extensor retinaculum is also to be avoided. Finally, the attachment of the stalk of the ganglion to the wrist capsule or the scapholunate ligament is isolated and removed while maintaining the important dorsal part of the scapholunate ligament. The capsular defect created by the excision of the ganglion is usually small. At times, this can be closed with sutures, but frequently it remains open or partially open. Before closing, hemostasis should be obtained with meticulous attention to avoid hematoma formation postoperatively. Some surgeons cauterize the area where the stalk was removed in order to help decrease recurrence. The efficacy of this maneuver is not well documented. After irrigation of the incision, the subcutaneous layer is sutured with an absorbable suture. Finally, the skin is approximated with a running subcuticular proline or a similar suture. A dressing is applied, and sometimes surgeons provide a brief splinting of the wrist for comfort. Potential complications of surgical incision should be kept in mind. They include recurrence, stiffness, wound infection, nerve injury, with possible neuroma formation, hypertrophic scarring, and sometimes artery injuries, particularly with volar radial carpal ganglion. In conclusion, the key points related to ganglion cysts are: ganglions can occur in many locations in the hand and wrist. Ganglions are not usually painful, especially when they are large enough to see and palpate. Ganglions are benign lesions. Ultrasound or an MRI can confirm the clinical diagnosis. MRI is usually not needed. Recurrence after aspiration is common, but less common after surgery. For more information, visit Hand Surgery Resource YouTube channel or sign on to Hand Surgery Source at www.handsurgeryresource.org or find the Hand Surgery Source app at the Apple Store or on Google Play. This is Larry Hurst. Thanks to you for listening to the Hand Surgery Resource podcast on ganglion cyst.